This is Chapter 17, Nursing Informatics. Okay, so what is nursing informatics? Nursing informatics is the specialty that integrates nursing science with computer science and information science. Information science, also known as computer software, so the computer software. It combines it in a way that helps nurses plan and deliver care to patients. So simply put, nursing informatics combines nursing science and information technology to help nurses manage and communicate data and information in nursing practice. It combines four sciences: nursing science, information science, computer science, and cognitive science. So cognitive science actually combines psychology, linguistics, computer science, philosophy, and neuroscience. It combines all those to help deliver care. It also looks at a person's perception and thinking and the way they understand and remember things. That's cognitive science. So nurses specializing in informatics are able to combine their nursing knowledge with technology to improve patient outcomes. The technology can be used to collect and analyze data in a way that allows the nurse to make the best decisions for the patients. So your book talks about nursing informatics consisting of a large number of disciplines such as evidence-based practice, population health, and genomics, just to name a few. But nursing informatics includes things such as electronic health records and telehealth, which use technology to help improve patient health. So these things have been implemented using technology to help improve patient health. So in today's healthcare society, at some point, just about all nurses perform some type of work with data, such as entering information in the electronic healthcare record, or using an electronic MAR to administer medications. Informatics nurses can work in a variety of settings, such as hospitals, or they can work as consultants for a program vendors. The program vendors are like companies that actually design the programs that nurses use. They can also work with program developers as nurse analysts, because many times individuals designing the programs have no nursing knowledge, and so you need that nursing background to incorporate into the technology to ensure it's going to be sufficient and actually do what it's supposed to do and improve patient outcomes. Informatics nurses have several roles. They can work as a software developer, a coordinator, tester, or a trainer. When we talk about a software developer, this individual analyzes the user's needs and design, test, and develop software to meet those needs. So they're analyzing what the nurse would need to efficiently do his or her job, and then design that software to meet those needs. The coordinator coordinates and leads meetings to inform the informatics nurses about information to analyze and change the system. The tester is the person that tests the system once it is approved, and then the trainer, once the system is finalized, the staff need to be trained. So the trainer would be the individual, conducting the trainer. So there are a variety of different roles, a nurse informatics or informatics nurse can take on. So nursing informatics was around before Florence Nightingale, actually. In your book on figure 17, figure 17.1 on page 443, it actually provides a timeline for milestones in nursing informatics. For instance, it talks about the database foundation being developed in 1860, the artificial intelligence foundation being established in 1936. Then it says the first board certification in nursing informatics was 1994. And then it also goes on to talk about artificial intelligence becoming a reality in 2010. So take a look at that timeline. There's several others on there that I didn't mention as well. Your book defines data to wisdom model as the model that gives nurse informaticists used to transform basic data into innovations that augment safe, quality healthcare. So in other words, it shows how nurses use facts to make decisions to provide care. And it also provides insight for how nursing informatics contributes to different levels of understanding, decision making, and evidence-based practice. So this model includes 4 steps. The 4 steps are data, information, knowledge, and wisdom. So data is your basic, raw, unstructured facts. Information is the data is given meaning and becomes information. Knowledge is when you combine the data and the information, that becomes knowledge. And then wisdom is when analyzed appropriately, the data, the information, and the knowledge becomes wisdom. So wisdom is the quality of having experience, knowledge, and good judgment. So to explain it, your book gives an example. So remember, I talked about 2010 being the year that artificial intelligence became a reality on your nursing informatics milestone timeline in your book. So the book gives you this example. So if we just throw the number 2010 out there, it's just basically raw data by itself, and it has no meaning. That number 2010, it could mean anything. I could be giving you the number of times something came on TV, or I could be giving you anything, or somebody's score or something. Just 2010 by itself is just raw data with no meaning. So if a person gives it meaning and says it's related to the nursing informatics milestone, it becomes information. So it's been given meaning, so it becomes information at that point. When you combine that raw data with information from the informatics timeline, it becomes knowledge. And then when the knowledge is interpreted as 2010 is the year artificial intelligence became reality, it becomes wisdom. So again, wisdom is the quality of having experience, knowledge, and good judgment. So I'm combining the data, the information, and the knowledge to gain wisdom. Each data point on the nursing informatics timeline we just discussed is divided into 3 categories of knowledge. You have computer hardware and software, data organization and integration, and artificial intelligence. So each of these points is linked to a science. So when we're talking about computer hardware and software, that's computer science. And when we're talking about data organization and integration, that's information science. And then when we're talking about artificial intelligence, that's cognitive science. So remember, we said nursing informatics combines nursing science with each of these sciences. And it's thought that Charles Babbage, Florence Nightingale, and Alan Turing developed nursing informatics by combining each of these sciences. Okay, so IBM, International Business Machine, in conjunction with Akron Children's Hospital, built the first health information system, also called HIS, in the early 1960s. This allowed healthcare workers to begin to integrate processes, decrease their paperwork, and improve the quality and safety of care being provided to patients. So we now have electronic health records, EHRs, and electronic medical records, EMR. The difference between the two has to do with integration of different systems working together. So an EHR is a comprehensive report of the patient's overall health, and it's considered to be integrated because it's able to communicate with other systems such as administrative systems, financial billing systems, laboratory systems, and even outside systems that's outside the facility itself. On the other hand, electronic medical records is considered a narrow view of a patient's medical history, and it's not integrated because it's located on a single computer system and it's not able to communicate with other computer systems. However, it can be located on several computers. So a hospital might have a EHR, whereas maybe a doctor's office or even a nursing home might have a EMR. In the 20th century, computer systems began to advance and became more portable and scalable. So when we talk about portability, that means the device can be moved from one location to another. And when we talk about sociability, that means the device can handle a growing amount of work. Integration. So when we talk about integration, that's when you have one or more device share data with another device. So for example, if you sync your smartphone to your desktop to share data, you sync your smartphone to your desktop, then you can share data from your desktop to your phone. That would be integration. Versus interoperability. Interoperability is the ability to share data on various devices regardless of the brand. So for example, when we talk about our televisions, no matter what type or brand of TV you have, it can receive signals from whatever the station is or the signal provider. So it doesn't matter what type or brand it is, it can still receive that signal from all those various ones. Versus when we talked about your desktop, obviously you'd probably have to have a smartphone. You can't just have a regular flip phone or something like that, probably to be able to share your data to your phone. So then we got nursing NANDA. So to make nursing diagnosis standards in 1973, NANDA, the North American Nursing Diagnosis Association, was created. And then to standardize terminology in 1994, the Clinical Care Classification, or CCC, was created. So when you hear the term artificial intelligence, you might think of something from outer space or something. But in healthcare, artificial intelligence is actually the ability of computer systems to perform tasks that would typically require human intelligence to make decisions or solve problems. For example, artificial intelligence has been used to make medical diagnoses with the use of MRI scans. It's been used to detect diseases. For example, you have the health trackers or the Fitbits or even the Apple Watches that collect data to monitor the patient's health. And it's also been used to automate administrative tasks, such as helping to streamline billing processes and decrease operational costs for healthcare facilities. So your book identifies several nursing informatics organizations. There's actually a table on page 441, box 17.3, that identifies some nursing informatic organizations and letting you know whether they still exist and actually giving you their website to refer to. And then also, when we talk about ANCC, that's the American Nurses Credentialing System, and it actually offered the first Nursing Informatics Board certification in 1994. Okay, so meaningful use is a term used to define the minimum standards set by the U.S. government for electronic health records. It outlined how clinical patient data should be exchanged between healthcare providers, between providers and insurers, and between providers and patients. So then we have the Health Insurance Probability and Accountability Act, also known as HIPAA. So this was legislation that was signed by President Bill Clinton, and its primary purpose was to ensure people can take their insurance with them when they go to a new job, and reduce healthcare fraud and abuse. And as healthcare records started to become computerized and digitized, the law incorporated regulations for privacy and security of records. And this privacy and security became the main focus for HIPAA. And in fact, probably most people you ask in healthcare today why HIPAA was established, they'll probably say because for privacy and security. And so it kind of became the main focus. And so then there were some requirements that were established by HIPAA. Your book actually outlines them. It says data had to be protected, anonymous, confidential, and collectible, but without individuality identifiable features. It says data had to be able to be placed in groups so that patterns within the data could be identified during collection. Data had to be meaningful, and data had to be inaccessible to anyone who should not have access to it. So if you shouldn't have access to it, then you shouldn't have access to it. So you shouldn't be leaving patient information around on the desk for people to walk by and read. If you have electronic MAR or whatnot for that you're administering meds with, you lock your screen before you walk away from it so people can't walk by to see your screen and things like that. So anything with patients information, identifiable health information on there should be protected. And so if HIPAA laws are there are laws in place that if HIPAA is violated, they are enforceable by law. All right, so in this computerized world today, patient health information has been bought and sold in the electronic marketplace. People have been able to actually breach the hospital records and access patient protected health information. Your book actually gives some pretty high profile cases in which patients' protected health information had been breached with healthcare entities. So some ethical issues surrounding this arise in nursing informatics. So who does the health data belong to? Does it belong to the patient? Does it belong to the organization that paid for the care, such as the insurance company? Does it belong to the healthcare provider? Or maybe does it belong to the facility that actually provides the care? Or does each of these groups of individuals have some type of stake in the information? So when we talk about societal benefit, you have two sides of that. You have individuals who are arguing for the individual's rights, and they say the information belongs to the person, and he or she has the right to say if that information is distributed to anyone else. Then you have those that take a utilitarian approach, or that of societal good, and says that basically society has the right to the information about disease occurrences, treatments, and outcomes. But when it all comes down to it, HIPAA actually says the client owns the information and it can only be released with permission. But in reality, access to health patients' protected health information is easy for a lot of groups. When we talk about consent, when we go into the hospital, get admitted to the hospital, we give generalized consent to treatment. And so, you think, okay, of course they got to share this information with, insurance companies or whatnot to, for your insurance company to pay. But a lot of patients don't realize that hospitals actually have to report certain information to, other entities as well. Your book actually talks about having to report injuries to the trauma registry. And so then the trauma registry, would get that information. But they also collect information about benign and malignant tumors. And then the public health department collects information about disease reports. So it's a lot of different organizations out there that is actually gaining access to your health information. But they should not, the information should not be identifiable. So they shouldn't say, they're reporting these injuries, or they're reporting, different things. It shouldn't be, identifiable information that they're reporting. But, as we saw in some of those other cases that your book identifies, your protected health information, your identifying information also gets breached, a lot of times as well. All right, unauthorized sharing of health information is unethical, and since the enactment of HIPAA, it's also illegal. And so we should not be sharing, our patient health information with any unauthorized individual. We want to maintain confidentiality. Confidentiality with our, maintaining confidentiality is the basis of trust and a therapeutic relationship, with our patients. However, there are certain situations when you have, say, FBI or the FBI, Federal Bureau of Investigations, or ICE, which is Immigration and Customs Enforcement, or NSA, National Security Administration, they actually have the authority to wiretap or access your information without a court approval. They can access any electronic information without court approval if there is if you have some type of link to a terrorist threat. So if they believe you're a terrorist threat, then they have the authority to access that without any court order information or anything like that. So when we talk about threats to security, so threats to security can either be accidental or intentional. So if you have accidental or intentional damage to paper or electronic health records. So threats might include, say, floods, tornadoes, fires, earthquake, electrical surges, any act of terror or anything like that might, be considered a threat. An intentional act is the action of a person or more than one person who's trying to damage or destroy or alter records. Obviously, paper records are a little bit easier to damage or destroy. You can, with paper records, you can erase or white out, or you can add to it or something like that. You can rewrite, different sections in a chart. You can remove the chart, destroy the chart, or make changes, to it. Whereas an electronic record is, as we've already seen, people have breached these electronic records, but of course it's a little bit more difficult to destroy these electronic records. But electronic systems have, they can, the virus checking systems to protect them. Some places where you work have the you have to change your password every 30 or 45 days or so, to maintain security or things like that. So depending on where you work, might have different security measures in place to try to protect your electronic health records. And then there's this worm. It's called Worm. Write once, read many, which is a program to try to prevent changes to electronic records as well. Okay, unauthorized sharing of healthcare information is unethical, and since the implementation of HIPAA, it's also illegal. So we should not be sharing, our patients' protected health information with any unauthorized individuals. Confidentiality is something that's very important to our relationship with our patients. It helps to build trust and build that therapeutic relationship with our patients. If we're not maintaining confidentiality, then of course they're obviously not going to trust us. However, there are situations when you have FBI, the Federal Bureau of Investigations, or ICE, which is Immigration and Customs Enforcement, or NSA, National Security Administration, and when they can actually, they have the authority to wiretap or access electronic health information without court approval if they suspect a terrorist threat. So if they suspect you're a terrorist threat, they do have the right or the authority to access that electronic information. And so that information can include physicians and nurses' records. It can include laboratory information such as your DNA, your blood type, your financial information. They have the authority to access, all of that information. So threats, let's see, threats to security. Threats to information security can either be accidental or it can be intentional, where you have damage to your paper or electronic health records. So when we talk about threats, that would be things like floods or tornadoes or fires or earthquakes or acts of terror or things like that. Maybe power outages or things like that can be considered a threat. Intentional acts, that would be actions by a person or people who are trying to intentionally destroy or damage the healthcare records. So your paper records are easier to destroy. You can erase them, you can white it out, you can add to it. You might even be able to rewrite whole sections of the chart. You can easily remove the chart or destroy the chart, or make any kind of, changes to it that might be difficult for someone to detect or find or whatnot. Now, electronic records, of course, we've already identified that that you can and they have been breached, but obviously they're a little more difficult to destroy than paper records. You have electronic systems have computer virus checking programs to protect them. Depending on where you work, you might have different security systems. The fact that it just drives me nuts, but some places you have to change your password every 30 or 45 days, but it's for security reasons. So depending on where you work, you might have different security measures in place that will help protect the electronic health records. HIPAA being revised. Okay, so in 2013, HIPAA actually had a revision in 2013, and it added this meaningful use to it. And so it was when it added the meaningful use, it was called this Medicare Electronic Health Records Incentive Program. And so your book actually defines meaningful use as this: the use of certified electronic health record technology in a meaningful manner. So, for example, using electronic nursing records or electronic laboratory results to guide patient care. So it should have some type of meaningful use. So it's based on 5 healthcare priorities. So the first being improving, when we're talking about meaningful use, based on 5 healthcare priorities: improving quality, safety, and efficiency, and reducing health disparities. 2, engaging clients and families in their health. 3, improving care coordination with other healthcare team members. 4, improving population and public health. And 5, ensuring adequate privacy and security protection for personal health information. So this is what this meaningful use incorporated with this. But one major challenge with trying to incorporate this, they were trying to get everyone to incorporate in a 2-year period. So this rapid implementation was a bit difficult for people trying to, get this implemented pretty quickly. As a result, quality care ended up suffering. So this was kind of difficult to get that put in place. So what it takes to be an informatics nurse specialist. Well, usually these are, specialists, of course. And so typically this person would need to have a bachelor's degree or higher, a bachelor of science degree in nursing or higher. They would need American Nurses Credentialing Center certification for nursing informatics. And they should be able to, when we talk about workflow optimization, so that's being able to implement processes that that improve the nurse's workflow and allow the nurse to provide safe quality care. Human factor error. So what that is referring to, in 2018, medical errors was identified as the third leading cause of death in the United States. That's 4 years straight. It was identified as the third leading cause of death was medical errors. So technology should be used to help decrease this. So when we talk about the human factor refers to the interaction of the human with a technology or an automated process. And so you should be using that process or that technology to help decrease the medical errors that have been occurring. All right, so just as you have the 6 rights of safe medication administration, you also have the rights of informatics. There's 5 basic rights of informatics. These rights include right time, right person, right route, confidentiality, and integrity. And your book actually describes these on page 451 in box 17.8. So when we talk about right time, data should be entered at the time it is received. So if you receive an order for a patient at 10 a.m., you shouldn't wait till 3 p.m. to enter it. So at the time it's received, data should be available in real time. So meaning when the labs are available, they should be, entered into the system and available in real time. And then disaster planning should be practiced and perfected. Most facilities will routinely practice their emergency preparedness plan. So say your fire drills, they have, have to practice those so many times a year so that the staff will be prepared in a case of a real emergency. When we talk about right person, only those with a need to know should know. So if it's not your patient, you don't have a need to know about that patient. So only those with the need to know should know. Also, data needs to be entered on the correct person. So making sure when you're entering data in the system on a patient, you have the correct patient. And then levels of security need to be implemented to ensure data is secure. So maybe you have a password that you have to enter to be able to access the correct patient or whatnot. Right route. So when we talk about right route, data should never leave the system. So you shouldn't be sending patient information on your cell phone to somebody or whatnot, which is not secure. Data should be available to anyone who needs it and has a right to it. So when we talk about that lab value, the nurse has a right that's taking care of that patient. The nurse taking care of that patient has a right to know that lab value. So that nurse should be able to enter her password and access that needed information. And security needs to be in place to ensure the route traveled by the data is right. So again, maybe that's your password or something that you might enter. When we talk about integrity, data should be protected so that it's not breached. So, depending on where you work, they might have different security systems in place. You talk about that password, maybe you have to change it every 30 or 45 days or something like that to ensure it's not breached. You shouldn't be sharing your passwords with other individuals either. And then when we talk about confidentiality, an entire chart is not needed for one laboratory order. So that means if you're entering a lab, if the lab is entering a lab or something like that, they don't need to have access to that patient's entire chart. They just need access to the section they need to enter the labs in or whatnot. And then security measures, once again, to put in place. So antivirus systems, firewalls, passwords, all those type things. Also, when we talk about rights of informatics, the book actually adds a few more rights. So right documentation, right form, and right response. So when we're talking about the right documentation, that's just talking about signing the document and electronic signature. So signing a document and having electronic signatures are just as legal as a handwritten signature, because the person signing should be uniquely tied to the signature. And then going back to like with meds and things like that, make sure you're not signing your medications before you administer the medication. You know, your patient could refuse that medication, or you could forget to give the medication, or whatnot. So make sure you don't sign for medication until after the medication is actually administered. Let's see, we talk about right action or right integrity. I want to go back to that for a minute. Right action or right integrity. Let's go back to that one for a minute. So you can't say, when we're talking about integrity, you can't say, I was just following the doctor's orders. So I just gave that medication because the doctor ordered it. You as the nurse yourself need to know what the medication was for, how the medication works. Are there any side effects that you need to know about? Are there any labs you should be checking before you give this medication? Do you need to check the patient's heart rate or blood pressure or whatever before you give this medication? And then act appropriately. You need to speak up and be an advocate for your patient. If there's something funny or suspicious about the order, then you need to question it. You need to talk to the doctor and question it before you give the medication. You can't say, I just gave it because the doctor ordered it. Also, when we talk about integrity, if a physician or anyone else asks you to document something that is not true, then you need to refuse that. You don't document something. I don't care if it's your supervisor or if it's a physician or whatever. If it's not true, you want to maintain a level of integrity in all your actions. And also, anything that's documented that's not true, it basically invalidates the entire document. It'll invalidate everything. Okay, so right form. When we talk about right form or data form validation, it helps the nurse to fill out forms in the correct format. And so you might have some places, it depends on like where you work. Some places might have something where you're charting, I don't know, even something like physical assessments and things like that as well. And then when you're charting it, all you have to do, it prompts you, okay, you need to make sure you document on the respiratory system, document on the urinary system, document your skin assessment, and then it might give you check boxes and things like that, and ensuring that you're completing the right information or documenting the right information for that person. And then right response, just like you have to get a response on your patient after you've given medication, you have to go back and check the response. You should have do the same with informatics. Did the data you collected, did it achieve or meet the goals that you were trying to achieve? So did it do what it was supposed to do? Okay, so outcome data and quality metrics are used in healthcare and other similar industries to evaluate electronic data. Outcome data are actually required by the government, insurance companies, and some providers as well. And they're required to demonstrate healthcare facilities are actually providing good quality care to patients. And so if it's determined that a healthcare facility is not providing good quality health care, then that healthcare facility can loses federal government funds. Quality metrics are data collection tools such as questionnaires or patient checklists that can be used to assess the quality of care. It can be used to assess patient outcomes or patients' perceptions, and it can also be used to assess the organization's processes and systems to determine, the quality of care that the facility is providing. So the outcome data will be then compared to standards, so predetermined standards, to determine how the facility is performing and if they need to improve in their patient care. Many of the quality metrics focus on client-centered care, but the American Nurses Association, their national database of nursing quality indicators, say employee satisfaction also affect the client healthcare experience, and it should be measured as well. So when you think about it, if you have satisfied staff that are not overworked and burnt out, they are more likely to go above and beyond to ensure patients have a great experience.